And we want to welcome you to today's webinar. We'll get started in just a few minutes. We'll give a few moments for continual link into today's webinar. We're already seeing the numbers of people who are logging on to be quite large. So we're nearly at 150 people so far, and I know that we have nearly 600 registrations. So thanks for your time, and we'll get started shortly. Okay, everybody. Well, welcome to today's webinar. I'd like to, on behalf of the Fight Colorectal Cancer team, in conjunction with our partners, Colon Cancer Alliance, welcome you all for a really interesting discussion about the latest advancements in research and clinical news. We're very excited today to present a number of the findings from some of the recent medical conferences. Go ahead and advance the slide. For medical science in relation to colorectal cancer. So as mentioned today, we will have Dr. Cathy Eng, who is from MD Anderson, who will be presenting today. Just a quick note that in terms of today's webinar, and I think that Danielle and team have noted, our webinars are archived and are available on our website. And if there's any specific questions or any information that you'd like to ask real time during our presentation, the chat function in terms of your GoToMeeting panel will provide you the availability to key in any questions that you might have. And just a quick note that, of course, through Twitter with both Colon Cancer Alliance and Fight CRC, we do have the Twitter accounts that we're able to follow as well. And so we just want to go ahead and launch into the introduction and a little more information. I did want to just mention to all of you that the Fight Colorectal Cancer team has actually is just introduced and working on disseminating our Guide in the Fight, which is a specific tool for patient resources around thinking about navigating colorectal cancer as stage 3 or stage 4, so late stage colorectal cancer diagnosis. And this workbook is really, really comprehensive in terms of providing planning resources, information about diagnoses, interpreting those terms in medical jargon into meaningful impact or meaningful information that will help impact the course of treatment and really help, again, guide through that fight. And so we're really excited that this has been a huge effort by the Fight CRC team over the last year and a half in production, and we're really excited that we're able to launch this fantastic tool, which can be found at our website at the Fight CRC website, which we can go into in a little bit further, and I think all those information are available in your GoToMeeting and the announcements that you've received today. I just want to also quickly mention that we really are dedicated to research and funding science, and so we really want to just remind people about the work that we're doing in terms of research and really advancing clinical initiatives specifically for treating late-stage colorectal cancer survivors with the LISA Fund. And I think as Dr. Eng is talking about the research that's happening and the advancements, this can't be done without specific and deliberate funding, such as the LISA Fund. And so with those who have really supported Fight CRC, we really appreciate that support because it really does help in the advancement in terms of hopefully improving quality of life of many cancer survivors. Just a quick note, of course, the disclaimer, this information is provided as an educational resource. It's in no way meant to replace direct medical care, and if there are any specific issues related to care, those should be directed to any medical providers or in emergent situations to 911 or specifically to an emergency room. But again, we're really hoping that this information could be a supplement in terms of the education and materials that you receive in conjunction with your medical team. So with that, again, I do want to actually talk a little bit, our our Colon Cancer Alliance team is on the phone with us today, and we are holding and hosting this webinar together, and we do want to give a special acknowledgement to the CCA team with Nancy Butterfield and team. And Nancy, could you actually spend just a quick moment before we introduce Dr. Eng to talk to us a little further about the Colon Cancer Alliance?
Sure. Thank you. We're happy to be here. I'm Nancy Butterfield, as she just said, and I'm the Patient Support and Outreach Manager at the Colon Cancer Alliance. I want to first thank our friends at Fight Colorectal Cancer for their partnership on this webinar, in addition to our volunteers, buddies, and all of our callers for joining us today. A bit of background about the Colon Cancer Alliance. We are the nation's oldest and largest patient advocacy organization dedicated to colon cancer. Our mission is to knock colon cancer out of the top 3 cancer killers, and we're doing this by championing prevention, funding, cutting-edge research, and providing the highest quality patient support services. Our patient support programs, like this webinar, are the heart and soul of our organization. I wanted to give a quick run-through of what we offer for patients, survivors, family members, and advocates. A couple of our newest programs are the Patient Support Navigator program, which serves patients throughout the entire continuum of care, from screening to diagnosis, treatment, and on through survivorship, as well as our new Blue Hope Prevention program, which provides qualifying individuals with financial support for the cost of a screening or other related expenses such as transportation, child care, and lost wages. In addition, we offer a toll-free helpline, an online community with a live daily chat, a peer-to-peer buddy support program, and financial assistance grants through our Blue Note Fund. Lastly, the backbone of the Colon Cancer Alliance is our community outreach volunteer program, which I think a lot of the callers on the call today are part of that program. Our organization wouldn't be where we are today if it weren't for the passionate volunteers who impact their communities around the country. I also want to let you know about our upcoming Breakthrough Summit series for newly diagnosed, long-term survivors, and young onset patients. In conjunction with our friends at CRISPR for Life and Stupid Cancer, we will be hosting Fighting a Smarter War on Colorectal Cancer. The first one will be December 4th through 6th at Georgetown in Washington, D.C., and the second one will be April 23rd through 26th in Denver. Registration will begin in the fall, so stay tuned. And we do have a slide in here somewhere about the conference, so that'll give a little more information. It's coming up. Finally, for more information about the Colon Cancer Alliance, our programs, or to listen to a replay of today's webinar, visit our website at ccalliance.org or call our helpline at 422-2030. And thank you so much for having us today and for coming to our webinar. And back to you.
Thank
April,
you.
Right?
Yes.
April, right? Okay, thank you, April.
Thanks. Thank you so much, Nancy and team. And apologies, the slides that Nancy mentioned will actually be at the close of today's webinar. So those information will be included and archived on both the Fight CRC and CCA sites. So thank you so much for that. And I do actually just want to mention that we are here today at the Colon Cancer Alliance offices and Fight CRC team in terms of helping bring this webinar to everyone, as we are actually working at a specific lobby day that Fight CRC has hosted, but there's actually a stakeholder meeting around advocacy issues and policy that a number of agencies, including Fight CRC, CCA, and CRISPR Life, have been involved with today, and with a number of our organizations. So we just want to also just give a specific mention to our work in the field. Before I actually introduce Dr. Cathy Eng, I do specifically want to take a little bit of time for us to administer a poll for those of you who are attending today, just to get a little bit of information about who's in our audience. And so I want you to, if you can please, through your specific voting, I need you all to please share with us what is your specific age group. So we have under 20, 20 to 30 years old, 30 to 50, 40 to 50, or over 50. And if you can actually provide information about your specific age range. Danielle, I don't know if you're able to help from this edge right here, able to launch that, and if not, that we might do that towards the end of the interview, or excuse me, at the end of the webinar. And it doesn't look like it's launching just yet. So with that, I will go ahead and introduce Dr. Cathy Eng in terms of just making sure that our specific so we can go ahead and cover the information today. So Dr. Eng is an associate professor in the Department of Gastromedical Oncology at the University of Texas in MD Anderson Cancer Center. She received her medical degree and is actually board-certified internal med and medical oncologist. And Dr. Eng will be presenting today the latest findings based on the ASCO, as well as other specific relevant information about the research and clinical findings. And so, Dr. Eng, we will actually go ahead and turn over the presentation to you to have you go ahead and provide information today. And thank you for joining us.
Thank you for having me here. I'm waiting for the slides to come up. I also just wanted to clarify, I was board certified in internal medicine. I'm no longer board certified because I'm so subspecialized now. Doing internal medicine is not as beneficial in regards to my research, and I will be recertifying for medical oncology just because it's that time frame for me. So today I just wanted to thank everyone for participating in this telephone conference. Some of you may have seen some of these slides already because I did present some information earlier in April regarding molecular markers. Can we get to the first slide, please? That's not the first slide. So it looks like we're having some technical difficulties. That's not my first slide.
Yeah, I'm sorry. Keep going. I'm trying to find the first slide.
It looks like you guys cut out about 5 slides. So really the focus of today is to really focus on where we are in regards to colorectal carcinoma and what are some of the developments that were presented at this year's ASCO meeting, which is the American Society of Clinical Oncology. So I'm just going to go ahead and keep on talking until you've addressed this technical situation here, just because I want to keep within the time frame. So in short, I just want to remind people that colorectal carcinoma is a malignancy which impacts several people worldwide as well as nationally. It impacts about 1.2 million individuals globally, and about half of those individuals will unfortunately pass away from this disease. And in the U.S., approximately a little less than 140,000 individuals will be diagnosed with this disease, of which 50,000 will still, unfortunately, suffer the consequence of being diagnosed late and either develop disease recurrence due to early stage disease that has, or the development of metastatic disease. And it looks like, are we able to pull this up? I'm not sure who's in charge of the slides here, but are we able to pull this up? I've got a black screen.
Dr. Eng, we are trying to make sure to insert those, but I think if you could progress to the slides that you have, and we'll make sure that if you're able to see do you see the current screen now?
It's not there. I see the first slide, yes.
Okay, so the first slide that you see is current development of metastatic colorectal?
Yes.
Okay, perfect, and we'll go ahead and advance through now, and we'll catch up with, please tell us which slide to go to.
Can you just hit the next slide? Okay, can you hit the next slide, please? Alrighty. So I apologize. There appears to be some technical difficulties. Hopefully this will not be any further of an issue for the rest of the presentation, because we realize everyone's busy. So really focusing on not only just standard cytotoxic or standard chemotherapy, but also focusing on so-called targeted agents and where we are in regards to treatment and how we can best utilize these drugs, as well as 2 drugs that were recently FDA approved, as well as 1 drug that has an expanded indication. In short, previously, before all of these therapies, I was not ready to go to the next slide. Can you go back where we were, please? Thank you. So in short, just to keep things in perspective, if you are a patient with metastatic disease, your expected 5-year survival, unless you can undergo surgical resection for your metastatic disease, is about 13%. So it's very important that we try to utilize all of the chemotherapies that are available to us as much as possible. And so without any treatment, the median survival of the patient can be as short as between 4 and 6 months. But with the addition of whatever therapies are available to you, and as long as you feel well, the median survival can basically almost reach 3 years. Next slide. This is basically just to give you a perspective about the various chemotherapy regimens in combination, and with the addition of bevacizumab, how we are in regards to overall survival. And as I mentioned earlier, we are nearing between 2.5 to 3 years with basically frontline chemotherapy. Next slide. These are the drugs that are currently approved that are the biologic agents that focus on anti-angiogenic or anti-VEGF therapy. What that means is anti-VEGF therapy is utilized in the hopes of trying to prevent further development of metastatic disease, as well as impact blood vessel growth. And we know that a tumor cell must obtain a blood supply to grow, survive, and metastasize. And so these agents, both in IV form as well as in oral form, we believe work in that fashion. Bevacizumab is currently approved in the first-line and second-line setting. Aflibercept is currently only approved in the second-line setting, and regorafenib is an oral agent that is basically approved once you have failed all available lines of chemotherapy, and it is given as a single agent, unlike the other two drugs, bevacizumab and aflibercept, which both work best in combination with chemotherapy. Next slide. And I'll be going into details in regards to those various drugs. So now we're going to focus on the basic updates regarding this so-called anti-VEGF therapy. Next slide. So we know that in general, 5-FU serves, or 5-fluorouracil, as some of you may know it, serves as the backbone of chemotherapy for many of our chemotherapy combined regimens. We also know that we can combine that in combination with irinotecan or oxaliplatin-based treatment, otherwise known as FOLFIRI or FOLFOX. But it was a decision about how to proceed and make this a better regimen, and that was really to focus all 4 agents together. So 5-FU, irinotecan, oxaliplatin, and leucovorin, which is not a chemotherapy agent. The idea was to look at the full combination, which is known as FOLFOX-IRI, and combine it with bevacizumab versus standard chemotherapy of FOLFIRI plus bevacizumab. And this is known as the TRIBE trial, which has been presented at 2 recent meetings. And this is in previously untreated metastatic colorectal carcinoma patients. And the goal of this study was to determine progression-free survival. Next slide. And patients only received a maximum of 12 cycles of therapy for each regimen, and then they were basically placed on just a 5-FU-based treatment alone with bevacizumab. The primary endpoint, as I mentioned earlier, was progression-free survival, and they noted with this extended chemotherapy regimen that there was an improvement in progression-free survival of 12.1 months versus 9.7 months. So if you utilized all of these drugs together, this appeared to improve your progression-free survival, or time until tumor growth, in layman's terms, by almost 3 months, about 2.5 months. Next slide. Next slide. No, sorry, can you go back? I'm not sure who's doing the advancement, but thank you. So the overall survival was also superior for this combination, although not statistically significant, but a difference of almost 5 months. So it suggests that the combined arm would fare better of 31 months versus 35.8 months, and patients were followed for a median of about 32 months. Now this regimen, some of you may be familiar with, because it is a standard of care in metastatic pancreatic carcinoma as well, although the schedule of the chemotherapy is a little bit different. Next slide. So in regards to response rate, which is a secondary endpoint, there appeared to be greater response for the full combination of 65% versus 53%, and that was found to be statistically significant. However, in regards to actually having no evidence of residual disease or R0 resection, that was not found to be statistically significant, although I would like you to keep in mind, obviously, that any type of surgical resection obviously is very dependent upon your interpretation of resectability as well as the technique from your liver surgeon. So in regards to response rate as a secondary endpoint, it did appear to be more favorable statistically for the full combination. Next slide. The toxicities that are very common with this regimen, as well as what is seen with pancreatic carcinoma, is that the patients are at higher risk for neutropenia, and that can be seen in about 50% of patients, and this was also seen in this study as well. So for any of you that are familiar with this regimen, our tendency is to only utilize it in very select settings, notably in patients with excellent performance status or good energy level, just because it can be a very difficult regimen to tolerate because it can cause a bit of fatigue, obviously, when you're utilizing all the available chemotherapy agents to you, but more importantly, it can cause neutropenia. So these patients, if you utilize it, need to be followed closely. And I would leave it up to the doctor's discretion whether or not they would want to utilize Neupogen or a Neulasta to help with the myelosuppression or the decreased white blood cell count that can be seen when providing this regimen. Next slide. Now, one other thing that I want to also highlight is that for many of the patients that don't have surgically resectable disease, as many of you know, we have to provide chemotherapy to these patients long term with an undefined duration of time, meaning we will provide you treatment as long as you're tolerating it well, as long as your laboratory tests are good, and as long as your energy level is good. But obviously, we don't want to burn out the patient, meaning we realize we can't keep you on the full dose chemotherapy agents for very prolonged periods. For instance, we know oxaliplatin can cause neuropathy, which can be difficult for patients, especially very active patients that want to focus on a good quality of life. So what we do know is that maybe we may want to pull back on some of our more toxic chemotherapy regimens and kind of consider a maintenance treatment. So next slide. So what many of us were doing were basically providing FOLFOX or FOLFIRI-based regimens to patients, and then we were cutting back on the irinotecan or the oxaliplatin arm, and basically providing the patients the 5-FU-based treatment only, kind of as a low-dose maintenance treatment until the time of tumor growth, and then reinitiating back the more aggressive chemotherapy, whether it be irinotecan or oxaliplatin, if you were originally on it. So the CAIRO3 trial was a study that was presented at ASCO, I believe ASCO GI, as well as updated again recently, looking at the role of maintenance chemotherapy. And I apologize, we should be crediting the original study and the original author. I thought it was on the slide, but I apologize, it's not showing up here for some reason. So basically, these are previously untreated patients, and they received a capecitabine-based treatment or oral 5-FU-based therapy with oxaliplatin and bevacizumab. And after 6 cycles of therapy, they were then randomized to either observation only versus maintenance chemotherapy with capecitabine and bevacizumab, as long as they did not have evidence of progression of disease. And then patients were then basically allowed to reinitiate oxaliplatin-based therapy if they were determined to have progression after being on this maintenance chemotherapy regimen. And really, this just validates what we were already doing in our practice. Next slide. So here they basically note if you provide some type of maintenance chemotherapy versus doing nothing at all after a certain interval, these patients fared better, 8.5 months versus 4.1 months. Next slide. And the primary endpoint was progression-free survival 2, which means the entire time period from the randomization and how that impacted basically the progression-free survival, or in layman's terms, time to tumor growth. And here you can see a difference of 11.7 months versus 8.5 months if you provided Xeloda, once again, which is oral 5-FU-based therapy with bevacizumab as your maintenance treatment versus not doing anything at all. Next slide. And the overall survival, although not statistically significant, also appeared to trend in favor of the maintenance regimen of 21.6 months versus 18.1 months. And this is after a follow-up of about 48 months. Next slide. So once again, the maintenance chemotherapy regimen is something, if you are a patient or a caregiver, it is something that your physician will likely consider after receiving about 4 months or so of chemotherapy, 4 to 6 months of chemotherapy, and they want to give your body a little bit of a break. They will remove the irinotecan or the oxaliplatin from your regimen and keep you on a 5-FU-based treatment as long as possible until you develop tumor progression, and then they will reinitiate the irinotecan or oxaliplatin-based treatment if appropriate. So it's really to give your body a break. And it's more of a quality of life issue as well. Okay, so I want to focus now, some of you, once again, may have seen some of these slides because I did present some of these slides earlier in the April session regarding the role of molecular markers in metastatic colorectal carcinoma. And so I just want to focus on some of the things that you can utilize when considering treatment options for patients with frontline untreated metastatic disease. Next slide. So a couple of definitions that I think are very important. A prognostic marker, obviously, is basically a marker that informs us of how your tumor impacts in regards to the overall outcome of your care. It has nothing to do in regards to your treatment, whereas predictive marker is helpful because it may tell you whether or not your tumor may or may not benefit from a particular drug. So if you are focused, such as a pharma company, on drug development, you are hoping that a predictive marker can be identified for the drug that you are currently trying to develop, because that obviously allows the physician to provide a more selective patient population specifically for that molecular marker. Next slide. So what we do note thus far is, in regards to all of those anti-VEGF agents or anti-vascular endothelial growth factor agents, a molecular marker has not been identified at this time. However, in regards to another class of agents called epidermal growth factor receptors, antibodies, there are molecular markers that can be helpful in letting you know whether or not to administer that class of drugs. Next slide. So KRAS was the first molecular marker that many of us started utilizing, and it's universally recognized as to be very, very important when considering any type of anti-EGFR or epidermal growth factor receptor antibodies. And treatments that involve this class include cetuximab and panitumumab. It is important because about 30 to 50% of all metastatic colorectal carcinoma patients have a KRAS mutation. And we recommend that when considering this class of drugs, you should always test the patient's tumor for the presence, whether or not it is there, of the KRAS mutation. And between the tumor within the colon or the rectum versus a site of metastatic disease, prior studies have indicated that for the most part, greater than 90% of the time, the KRAS mutation in the primary tumor itself versus the site of metastatic disease is very similar. And so it's very important whenever looking at any new patient with metastatic disease, we always test our patients for the KRAS mutation up front, because that can help guide therapy down the road, if not for frontline treatment. What it doesn't tell you is whether or not the patient will definitely benefit from treatment, even if you are KRAS wild type. What we do know is if you are KRAS mutant tumor type, you do not benefit from this class of drugs. Next slide. So this is a very good cartoon that I love to utilize that was published about 7 years ago, which gives you an idea of why it's important to test for the KRAS mutation. So we know cetuximab is an antibody that is meant to bind the ligand of the EGFR receptor. So in cartoon A, that is the standard pathway in regards to the EGFR receptor. And in cartoon B, it is believed if you provide cetuximab or its sister drug panitumumab, if you bind the ligand, you hope it doesn't activate any of those downstream pathways. That's the way it's supposed to work. However, in diagram C, in red there, you see what happens in the presence of the KRAS mutation. Once again, that's present in 30 to 50% of all colorectal carcinoma patients. And when it is present, even if you use cetuximab, it does not prevent downstream activation of the other pathways. And so that is why this drug is not helpful in the setting of the KRAS mutation if it is present. Next slide. Another mutation that is important more for prognostic reasons and much more rare, it's less than 10% of all colorectal cancer patients. This is the BRAF mutation. And it is mutually exclusive, meaning if you have the KRAS mutation, you don't necessarily have to test for the BRAF mutation. Because it's rather rare, though, all the studies have not been beneficial in determining predictability of the role of this mutation in regards to the EGFR antibodies, but we clearly know that it is prognostic, and we suspect it is predictive. However, all the studies have not been powered to determine that information. Next slide. And I'll give you examples of why that is important as well in a few slides. The NRAS mutation is also more recently discovered. It is in less than 5% of all metastatic colorectal carcinoma patients. And once again, it is also mutually exclusive. It does have a role in regards to the KRAS itself. Even if you're wild type, if you have the presence of the NRAS mutation, it actually can demonstrate that it negatively impacts the benefit of EGFR therapy in the setting of treatment, even if you're a KRAS wild type. And I'll give you examples, and I know that sounds a bit confusing, but I'll give you examples of why this is important as well. Next slide. So once again, I talked to you earlier about treatment-naive patients that receive anti-VEGF therapy, once again, mostly focusing on bevacizumab in the frontline setting, because that is the drug that is approved in the frontline setting. Now we're going to focus on frontline chemotherapy treatment with the use of anti-EGFR therapy. Next slide. So this basically is the PRIME trial, and I show this to you as an example because when it was reevaluated and recently published last year, it has some very important points that really impact how we treat patients currently. So once again, this is a treatment-naive patient population, and patients were randomized to just chemotherapy alone with an oxaliplatin-based treatment, otherwise known as FOLFOX, or with the addition of panitumumab. So that's the fully human monoclonal antibody against the EGFR receptor. And please note there is not a third arm here that includes anti-VEGF therapy. This is purely chemotherapy plus or minus the anti-EGFR antibody. All patients were required to be KRAS wild type, meaning they didn't have the mutation. The primary endpoint was progression-free survival. So there were two analyses completed, and I'll show you the original one and then the updated analysis. Next slide. This is a very big study of over 1,100 patients. Next slide. And I just want you to keep in mind, not only did they originally look at the presence of the KRAS mutation originally, whether you were wild type or mutant tumor type, so the updated analysis was only with KRAS wild type patients, but they also decided to look at the other rare RAS mutations. So in one of the slides earlier, I informed you that the KRAS mutation is present in 30 to 50% of patients, and it's commonly found in certain codons. And people used to only look at those more common codons. But now we're beginning to look at the impact of other rare RAS mutations. So even if you are KRAS wild type, and once again, I don't expect you to memorize this slide by any means, but basically to inform you, if you're KRAS wild type, but also have the presence of one of these other rare RAS mutations, it can negatively impact the benefit of being wild type. So here, so codon 12 and 13, the top row, exon 2, those are the most common ones, and beneath that are the other more rare RAS mutations. So for instance, KRAS mutation in exon 3, codon 61, that's very rare. And then going down from there, you see 117, 146, etc. So those are the other more rare RAS mutations. Next slide. So this is basically a breakdown of the study, and what you need to know is that originally this trial was presented and published in, I believe, the Journal of Clinical Oncology, and then it was updated in the New England Journal of Medicine 2013. And what they basically determined was that about 16 to 17% of patients actually had the presence of these other rare RAS mutations. And how does that impact your treatment? So I'll give you an example in just a second. Next slide. So this is basically to give you an idea. So in slide A, basically we're looking at progression-free survival. And in slide B, we're looking at basically the updated analysis in regards to progression-free survival. So in regards to progression-free survival with FOLFOX plus or minus panitumumab in wild-type patients, there was a benefit of 1.6 months, so 8 versus 9.6 months for the combination. However, in basically in diagram B, if you looked at progression-free survival and you were KRAS, not only KRAS wild-type, but also had the other, also your tumor type was evaluated for the other RAS, potential other RAS mutations. If all those were wild-type as well, there was a benefit, a greater benefit in regards to progression-free survival of 10.1 months versus 7.9 months. In regards to overall survival, I think this is kind of where it's more poignant, really noticing on diagram D, a difference of almost 6 months if you were all RAS wild-type, meaning you had no mutation present at all. And basically, it was a difference of 26 months versus 20.2 months. So this indicates to us that if you are going to utilize this group of drugs, the anti-EGFR therapies, you should be not only testing for KRAS, but you should also be testing for the other rare RAS types. Next slide. I think this slide is very important because it does indicate to us that what happens if you were KRAS wild type, but you had the presence of one of these other rare RAS mutations. So here is a prime example. So chemotherapy alone is 8.0 months. But if you have the presence of one of those rare RAS mutations, which overall has been found to be in about 16 to 17% of patients thus far in the largest phase 3 trials completed to date, look at the benefit of FOLFOX and panitumumab. In fact, your investigational arm, it does worse than the control arm. So even if you're a KRAS wild type, but yet have the presence of one of these rare RAS mutations, it actually ends up being more detrimental. So you actually fare worse than the control arm alone. So once again, suggesting you need to test not only for KRAS, but as well as for these other rare RAS mutations. Next slide. And once again, looking at overall survival, so I just showed you earlier, your median overall survival if you were all RAS wild type was 26 months versus 20 months for the benefit of combined chemotherapy with panitumumab versus chemotherapy alone. Here, in regards to overall survival, if you received chemotherapy alone, that was 18.3 months. But if you were to add panitumumab, the anti-EGFR antibody again, and you had the presence of one of these rare RAS mutations, it actually was worse than the control arm. So 17.1 months versus 18.3 months. So once again, emphasizing the importance of testing your tumor specimens early on. Next slide. So basically, in summary, I think I basically had mentioned this already, about 17% of patients in this study did have one of those additional rare RAS mutations. And so it's very important to test these tumor specimens very early on. And I tell all doctors, some doctors say, when should I do it? And I always tell them, please do it as soon as you meet the metastatic patient, because obviously it's very hard to retrieve tissue later on if it's been filed away in a warehouse or it's at another hospital and you have to put in a request form for that specimen. So please do it early on so you can help guide your patient's therapy appropriately. Next slide. Okay, so I've showed you two different examples of basically anti-VEGF therapy in combination with chemotherapy and anti-EGFR therapy in combination with chemotherapy. But where is the study where they've been compared head-to-head? And this is where we've been really waiting for the data to be presented to us, because there was a tendency previously to only utilize anti-VEGF therapy in the frontline setting and to reserve your anti-EGFR therapy in your third or fourth line setting, in part because anti-EGFR therapy can cause a rash and acne, and sometimes patients don't want those types of toxicities associated with their treatment. But keep in mind, anti-VEGF therapy also can cause increased blood pressure in about 30 to 35% of patients, and obviously it's not beneficial to utilize in a patient that's had a recent cardiac event that's actually contraindicated to the role of anti-VEGF therapy up front. So where is the trial that has actually compared these two approaches head-to-head? So here is some recent data that has been published as well as presented most recently at ASCO just this June. Next slide. So the PEAK trial, I just showed this to you because it was published before the phase 3 oral presentation that I'm going to focus on. The PEAK trial was a smaller phase 2 study which compared, and I apologize, we had fixed this slide, but it looks like it has not been fixed. It should be FOLFOX plus panitumumab versus FOLFOX plus bevacizumab. And these were basically in KRAS wild-type patients. It was a smaller study of 285 patients, and the primary endpoint was progression-free survival. So comparing anti-EGFR therapy in combination with chemotherapy versus anti-VEGF therapy in combination with chemotherapy. Next slide. And here, when just looking at the KRAS wild-type, so the very generic KRAS wild-type patient population, it looks like there was a benefit in regards to progression-free survival of 10.9 months versus 10.1 months, but also in regards to overall survival of 34.2 months versus 24.3 months. And response rate was basically comparable between the two arms. Next slide. However, when you want to look specifically with the addition of those other rare RAS mutations, very small subset, about 80 plus in each arm. Please keep in mind this is only a phase 2 study. You'll see a difference of progression-free survival of 13.0 months versus 9.5 months. So indicating, very much like the PRIME trial, if you are all RAS wild type, it suggests that you may benefit more for anti-EGFR therapy upfront versus what we commonly utilize as upfront therapy, which is FOLFOX bevacizumab. The overall survival was also improved to 41.3 months versus 29 months. Next slide. So there was a trial called the FIRE3 trial that looked at this in a bigger setting. This is 592 patients. This was presented last year as well. Was updated at last year's ESMO meeting as well. Primary endpoint was response rate, so not a very common primary endpoint for a phase 3 trial. We tend to look at progression-free survival and overall survival for phase 3 trials because usually you are trying to expand your FDA indication. However, these drugs are already FDA approved. Next slide. So the response rate was no difference between the two arms. It was not found to be statistically significant, so the primary endpoint was not fulfilled. Next slide. The progression-free survival was also no difference between the two arms. No difference was noted. Next slide. The secondary endpoint of overall survival, though, appeared to show a benefit for receiving cetuximab for upfront therapy in the frontline setting of a difference of 3.7 months versus standard chemotherapy with anti-VEGF therapy. Next slide. Now, the investigators, very similar to what I showed you earlier in the PRIME trial, they then decided to look at those other rare RAS mutations. And in the PRIME trial, I showed you 17% of patients had those rare RAS mutations. And here it was very similar, 16%. Next slide. And once again, can you go back a slide, please? Once again, these are the other rare RAS mutations they are looking at. Next slide. If you are KRAS wild type and were wild type for all the other rare RAS mutations, this appeared to show a benefit for the role of cetuximab, anti-EGFR therapy, in the frontline setting versus anti-VEGF therapy, a difference of 7.5 months. Very similar to PRIME, suggesting that, once again, if you have a patient that you're meeting and you're considering anti-EGFR therapy first line, you have to test your patient not only for the presence of the KRAS mutation, but if they are wild type, you should also test them for those other rare RAS mutations. And I understand not all facilities do have the ability to test it at their own university or their own medical center, and you do have to send it out. My recommendation that I've told other community practice physicians is please talk to your pathologist to make sure that they are ordering all the appropriate molecular markers to ensure that your patient does benefit potentially from this class of drugs. Next slide. So this is basically a summary. So if you were basically all RAS wild type, I showed you a difference of 7.5 months. That's the second row. Just to emphasize the importance of the presence of testing, even if you were KRAS wild type but had one of those other rare RAS mutations, it actually was a negative benefit to you, 16.4 months versus 20.6 months. So you don't fare as well if you have one of those other rare RAS mutations. What is even more notable, and I bring this up because we're going to be discussing it later, is that in the presence of the BRAF mutation, once again, that's in less than 10% of patients, these patients overall, despite whichever therapy you give them, they have a very poor prognosis, and their overall survival is about a little over a year. Next slide. And also to add on to that note, so at our institution, not only do we test for KRAS, not only do we test for the other rare RAS mutations, but we always test also for the BRAF mutation, for the presence of it, to look at prognosis. Okay, so regarding this FIRE3 study, this has only been presented. It has not been published to date, and obviously we're looking forward to the mature data to analyze it a little bit more to see if truthfully, is it the sequence that matters? Do you have to give anti-EGFR therapy to patients that are all RAS wild type? Does it sincerely make a difference in regards to their overall survival? Next slide. So we were waiting in the U.S. for this trial to be completed. This is the CLAGB SWOG 80405 study. This was an intergroup trial in treatment-naive patients, basically conducting a head-to-head comparison of cetuximab versus bevacizumab in treatment-naive patients. And this was presented as at the plenary session at this year's ASCO. Next slide. So this involved over 1,000 patients, and the primary endpoint was overall survival. It was left up to the physician whether or not they wanted to utilize a FOLFOX or FOLFIRI-based regimen. 70+% of physicians chose FOLFOX as their preference for the systemic chemotherapy backbone. This trial was amended several times. It eventually incorporated the new literature regarding the KRAS, the need for the presence of the KRAS wild-type patient population. Once again, it's between cetuximab versus bevacizumab. Next slide. I think we've kind of gone over this. These were basically patients with a performance status of 0 to 1. Next slide. These were basically the goals to demonstrate an improvement of about 5.5 months for the addition of anti-EGFR therapy if you were more selective in this patient population. Next slide. So these were the overall results, and this was the primary endpoint. So in blue is the cetuximab arm, and yellow is the bevacizumab-based arm. And as you can see here, there was basically no difference between the overall survival of either regimen in this patient population. It was not statistically significant. However, what is noted is that, once again, the median overall survival is surpassing 2 years and is heading towards the 3-year interval for this patient population. Next slide. There's no difference in progression-free survival between the two arms as well. Next slide. In regards to a substratification based upon chemotherapy backbone, as I mentioned earlier, 70+% of patients received an oxaliplatin-based regimen. As you can see here, it appeared to suggest that if you were KRAS wild type and had received cetuximab in combination with your chemotherapy, you appear to fare better of 30.1 months versus 26.9 months. Next slide. And for the irinotecan-based regimen, although it also appeared to indicate that there was a greater median survival with this regimen, even more so than the oxaliplatin-based regimen, basically this was a smaller subset. So that it's basically underpowered. Next slide. I think the toxicities are not anything that was unexpected. I'm really not going to elaborate upon that. Obviously, hypertension is very common with bevacizumab-based therapy, and a rash is more common with cetuximab-based therapy. Next slide. So this is some of the data that is currently pending, response, looking at second-line treatments and later treatments, as well as looking at extended RAS analysis, very much like the PRIME trial had completed, as well as the FIRE3 trial had completed. Next slide. So this slide has been basically comparing the two big phase 3 trials, and then I threw in PEAK, which, although it's a phase 2, did have the original published data. So once again, you can see the chemotherapy backbones varied between the two. The primary endpoints were also very different between all 3 studies. Once again, when looking at the expanded RAS analysis, that is not yet available for the 80405 study. Further analysis regarding response and subsequent lines of therapy are still pending for FIRE3 as well as 80405. So all of these two big phase 3 trials are not published yet. They've only been presented in format. Next slide. So I'm just going to touch upon how you would basically focus, not only now moving from front line, but focusing on second line therapy and what your options are. Next slide. So I know some of you may have seen this data if you are currently in practice, but I understand obviously there are individuals that are not in practice, that are caregivers or patients that may be interested in learning what is available and up and coming. So for second-line treatment, I just wanted you to be aware that there was an analysis completed basically looking at the role of continuing bevacizumab beyond your first-line treatment, meaning if you had been on front-line treatment with bevacizumab-based therapy and then demonstrated progression, you are obviously always switched to a different second-line chemotherapy backbone. So what the investigators decided to do was to look at the benefit of continuing bevacizumab with that second-line chemotherapy or just giving chemotherapy alone. The primary endpoint of the study was overall survival. Next slide. And in short, basically, they demonstrated that an improvement in overall survival was achieved if you had received the addition of bevacizumab with your second-line chemotherapy, even if you were already on it in the first-line setting. And that was a difference of 11.2 months versus 9.8 months. Next slide. As a result, the FDA approved bevacizumab not only in the front-line setting, but in the second-line setting with continuation as part of your second-line regimen. The other drug that has recently been FDA approved is known as the VEGF trap. It is specifically only approved in the second-line setting. It's a little bit different from bevacizumab. Bevacizumab only binds VEGF-A. VEGF trap not only binds VEGF-A, but also binds VEGF receptors 1, 2, and has a very similar half-life, and also binds placental growth factor. Next slide. So this is the trial that resulted in its FDA approval. This is in the second-line setting in combination with FOLFIRI or irinotecan-based treatment. So all patients had to have received prior oxaliplatin in the frontline setting, and then they were randomized to either chemotherapy plus or minus aflibercept. Primary endpoint here, very similar to the trial I just showed you earlier of overall survival. Next slide. And in short, they were able to demonstrate an improvement in overall survival of 13.5 months versus 12.06 months for the combination of adding aflibercept to your chemotherapy in the second-line setting. So basically, in the second-line setting, you have two options. You can continue bevacizumab if you were already exposed to it in the front line, and now you're moving to second line, or if you have an irinotecan-based backbone for therapy known as FOLFIRI, you can add aflibercept to your regimen in lieu of bevacizumab. Next slide. We can skip the slide. And what you should be aware of is the toxicities are somewhat similar. Now, in the aflibercept trial, some patients did report some increased incidences of diarrhea. In part, that may be because when you participated in this trial, your second-line treatment was full-dose chemotherapy, whereas in the other trial that I showed you earlier, you were allowed to receive, if you were already basically on a reduced dose of chemotherapy, you were allowed to continue your next chemotherapy regimen at that reduced dose. So that may have accounted for some of the diarrhea as well as some of the neutropenia that was seen. Both drugs do cause hypertension, and that's just a class effect for this group of drugs. Okay, next slide. So now I want to focus on specifically on patients that have received multiple lines of therapy. What are their options? So I've just shown you in the frontline setting, you can receive bevacizumab. If you're all RAS wild type, you may want to consider anti-EGFR therapy in the frontline setting. That's a possibility. In the second line setting, I've shown you can continue bevacizumab, or you may change it to aflibercept as long as you're using a FOLFIRI-based regimen. And now here's a setting for patients that have received all lines of therapy. And I think it's also very important to keep in mind that if you're a KRAS mutant, if you have KRAS mutant tumor type, once again, that's 30 to 50% of patients. Obviously, these patients have less options. They can't go on to receive, once again, they cannot go on to receive anti-EGFR therapy. So that is a whole class of drugs that they will never see. And as a result, it's very important that we continue on our research because obviously that's a large number of patients that don't have as many options. So regorafenib is basically an oral agent that not only blocks part of the VEGF family, but as you can see here, it blocks various other receptors as well. It is the only other oral agent besides oral capecitabine or oral 5-FU. It is approved as a single agent based upon the study I'm going to show you here. Next slide. So this was a trial that resulted in its approval. This is basically for patients, once again, that have failed all lines of therapy. They were to receive regorafenib, and the recommended FDA insert says 160 milligrams daily for 21 days, and each cycle is given is every 4 weeks versus placebo. Primary endpoint was overall survival. Next slide. And basically, this is the primary endpoint with the use of regorafenib of 6.4 months versus 5.0 months. So a difference of 1.4 months in regards to overall survival. So it fulfilled the primary endpoint. What you should know is if you ever utilize this class of drugs or if you are a patient, I do not recommend you start this drug at its recommended dose of 160 milligrams daily. Most patients develop what's called a hand-foot skin reaction, which is blistering and calluses of your hands and feet, which can be very painful. It usually occurs within the first 2 months of therapy. It's more likely to occur within the first 2 months of therapy. So most of us actually start off at a dose of 120 milligrams. So that's 3 tablets instead of 4. And you can dose escalate after that 2-month period. That's what I recommend to most physicians if you're not familiar with utilizing this drug. And I've not seen any impact on efficacy, and many people, such as myself, that use this drug fairly regularly can tell you the same. We don't believe that starting off at a lower dose impacts efficacy. We believe it's beneficial because patients have better quality of life, and so they don't have to deal with that severity of the hand-foot skin reaction. Next slide. Okay. So this is the latest data. This is a drug called TAS-102. It's been in development for several years. It's created by a Japanese company, and basically it's a formulation, almost like a formulation of 5-FU. It is administered IV, and they created this study very similar to the regorafenib trial I just showed you earlier called CORRECT. So this was, once again, all heavily pretreated patients, failed all lines of therapy, good performance status, and they randomized patients in a 2-to-1 fashion, about 800 patients overall, to the TAS-102 agent versus placebo. Primary endpoint here is overall survival. So I showed you a difference of 1.4 months with regorafenib in the same setting. Next slide. Unfortunately, I do not have the original slides for this presentation. It was just presented a few weeks ago, but this is the data from the media, the press release. The median overall survival was improved with 7.1 months if you received TAS-102 versus placebo of 5.3 months. It was also improved for progression-free survival in regards to TAS-102. The toxicities that are seen that they reported appear to be about half of patients do have some type of neutropenia, but they don't report any hand-foot skin reaction or anything else. It's mostly impact on blood counts. I suspect, and I'm just hypothesizing, but I suspect it is likely to be submitted for expedited FDA approval, very much like regorafenib was when it was originally presented. So I'm sure we will hear more about this drug in the future. Next slide. Okay, so very quickly, before we head on to more novel agents, I just want to highlight one important point. I told you earlier, if you are all RAS wild type, you may potentially benefit from anti-EGFR therapy up front. But there is a specific setting that is not a good idea. And I think it's very important for practicing physicians and patients that are thinking about liver resection to see this data. Next slide. So the new EPOC trial looked at the role of providing chemotherapy plus cetuximab, the anti-EGFR therapy, before surgical resection as well as following surgical resection versus chemotherapy alone. And the primary endpoint was progression-free survival. And the intent originally was to enroll over 600 patients. And the majority of patients received oxaliplatin-based therapy. Next slide. This was presented at ASCO last year. It has not been published yet as far as I'm aware. They are looking further into the correlatives regarding the other RAS mutations, etc. But there was a huge difference in regards to progression-free survival if you had received cetuximab in what we call the neoadjuvant setting, so before surgical resection and after surgical resection. A difference of 20.5 months for just chemotherapy alone versus 14.1 months for the addition of cetuximab. So actually the study was stopped prematurely as a result of the significant decline in progression-free survival. So thus far, once again, I've only seen this presented. I've not seen the final data. This indicates in the setting of liver resectable patients, you should not receive anti-EGFR therapy upfront as part of your treatment regimen in combination at least with an oxaliplatin-based therapy. Now, this is very different, obviously, in all those other trials I showed you, which were both FOLFIRI and FOLFOX-based that demonstrated benefit in the surgically unresectable patient population. But this study was specifically for patients with liver metastases that were considered resectable. So we do not recommend oxaliplatin with cetuximab in a surgically resectable patient population at this time point. Next slide. Next slide. So I just wanted to show a couple trials that are going to be up and coming. Next slide. So the BOS2 study is looking at the KRAS wild-type patient. Here we are once again comparing anti-VEGF to anti-EGFR therapy versus just chemo alone. So this trial is I believe it's ongoing. Next slide. The BOS3 trial, the last time I checked, this was not finalized, but it's basically looking at chemotherapy plus or minus aflibercept, specifically in the KRAS mutant tumor type. So these are patients that can't receive anti-EGFR therapy. Next slide. And it's really just to give you an idea of what trials are up and coming for liver resectable patients. Okay, next slide. I just want to focus this very last few minutes on some of the up and coming drugs. So the Rainbow trial is looking at it. This was a trial that was completed in gastric cancer. It was a positive study, phase 3 study, looking at a drug that specifically blocks VEGF receptor R2, and it is going to be approved likely in gastric carcinoma. This drug was looked at in a trial, next slide, specifically for second-line metastatic colorectal carcinoma patients. Next slide. We do not have the results of this trial, but this is the study design. Second-line trial looking at FOLFIRI plus or minus ramucirumab. Primary endpoint is overall survival. So this is something you should keep your eyes out for in regards to potential new developments for drugs that may be positive and may be an option for patients in the future. Next slide. I want to show this very briefly as well. I've done a lot of work regarding c-Met agents, and basically c-Met is another pathway that's involved in the development of colorectal cancer as well as hepatocellular carcinoma and gastric carcinoma. Next slide. And I show you here two of the drugs I've worked with previously, AMG 102, which is a hepatocyte growth factor monoclonal antibody, which binds specifically the c-Met receptor. ARQ 197 was an oral c-Met inhibitor. Both of those trials were randomized phase 2 studies. What we did learn from these trials is that unfortunately, a lot of the tumor specimens were from the original colon or rectal tumor, and what we do know is that actually c-Met expression is higher at the site of metastatic disease. So I would encourage anyone that's investigating into any of these agents that you should biopsy the site of metastatic disease. At our institution, we are expanding upon this further in regards to colorectal cancer, not only looking at c-Met expression, but specifically at c-Met amplification, which is likely to be in less than 20% of patients, but we are requesting specimens to be biopsied, if not already completed. Next slide. Next slide. Okay, here we go. So, these are, can you go back slide? So METMAB, this is a trial that's already been completed. We do not have the final results. This is basically a monoclonal antibody against c-Met. The study was a randomized phase 2 study. And this study was conducted by the investigators at Sarah Cannon Cancer Center. So keep a lookout for this in regards to this study. Next slide. This is the trial that we'll be conducting here at MD Anderson Cancer Center, looking at single agent AMG 337, which is a more up-to-date c-Met inhibitor, and once again, we're looking specifically at the role of amplification in the select patient population and focusing on the site of metastatic disease, which we believe is the more appropriate site to test for in colorectal patients. Next slide. Here is just a list of trials that are being developed in both aflibercept and regorafenib, so I don't really want to just go into full details, but just to give you an idea of what's up and coming regarding these agents. Next slide. And last but not least, I just want to take 2 more minutes to focus on rare population subsets. Next slide. So I talked earlier about the BRAF mutation, less than 10% of patients, very poor prognostic factor. Next slide. Just so you know, this drug, vemurafenib, is approved. I'm sure most of you are aware of this in melanoma. It's because BRAF is expressed in about 60% of melanoma patients. However, in colorectal cancer, once again, less than 10% of patients. As a single agent, not effective. We actually looked at this at our institution. In collaboration with others, but being led by Dr. Scott Kopetz at our institution. Only 1 out of 21 patients had a response. Next slide. Next slide. But I want to remind you what a poor prognostic factor, once again, BRAF is, and in a very small subset of patients, if they were provided the full FOXIRI regimen, they appear to fare best if they had the presence of the mutation and received full FOXIRI, so a very aggressive regimen up front for these patients. Next slide. Next slide. I mentioned earlier in the FIRE3 trial, these patients only survive a little over a year, and so that's why it's very important to try to be as aggressive with them as possible and to try to provide selective therapy to them. Next slide. So there was a phase 1 study that was presented at ASCO focusing on the combination regimen of irinotecan and cetuximab with vemurafenib. Next slide. If we could just go, please, to the picture of the case. In the interest of time, and because we seem to be having some technical delays. Next slide. There we go. So in short, there appears to be benefit for the combination of irinotecan, cetuximab, and vemurafenib. So vemurafenib as a single agent in the presence of the BRAF mutation is not beneficial, but in the combination with chemotherapy, it appears to be beneficial. So here on the left is a pre-treatment CT scan highlighted with purple, and in blue on the next picture, you can see there's a regression of tumor after only 4 cycles of treatment. Next slide. Next slide. Next slide. So in short, this is a trial that is going to be conducted through the cooperative groups. So if you have a patient with a BRAF mutation, I just want you to be aware that this trial will likely be open, we hope, by in the next 2 to 3 weeks, specifically for the patient with a BRAF mutation, no prior anti-EGFR therapy provided, we're basically looking at second line plus of therapy. So they may have been previously treated with 1 line of treatment. Primary endpoint here is progression-free survival. So standard chemotherapy plus or minus vemurafenib. This is a phase 2 study, and we highly encourage individuals to participate in this trial because of this rare population subset. Next slide. We're almost done here, but really I've heard a lot of discussion about what is the role of immunotherapy in colorectal cancer. I can simply tell you right now, next slide, that immunotherapy appears to definitely be, we know there's benefit in melanoma. There appears to be benefit in non-small cell lung carcinoma. But its role in regards to colorectal cancer has not been fully established. So here, this is a very classic paper from the New England Journal of Medicine in regards to a patient with advanced melanoma. Next slide. And this is a trial that is ongoing, and I thought people should be aware of it. So there is something called MSI high, so which is may occur in about 10 to 15% of all colorectal carcinoma patients. So some of these patients may have inherited risk factors such as the Lynch syndrome for developing colorectal cancer, and these patients commonly are found to be MSI high. There appears to be benefit potentially for immunotherapy in this select patient population. In the original phase 1 study of one of these of nivolumab, which is which is a PD-1 antibody, so it's programmed death receptor antibody working with the immune system. There was 1 patient with colorectal cancer that had a complete response. So Bristol Myers has decided to expand upon this concept and has created a trial specifically in MSI high patients. MSI high is also found in about 15% of patients that don't have an inherited risk factor. It is a sporadic development of colorectal cancer that you can also be MSI high. Bristol is also looking at patients that don't necessarily have to be MSI high, but are just standard metastatic colorectal carcinoma patients. That trial is also ongoing at this time. And I just wanted you to be aware these trials are open. The MSI high study as well as the MSI stable study are both being conducted nationally at this time. Next slide. So in short, obviously there are many treatment options for patients with colorectal carcinoma. Once again, if you are meeting a patient for the first time, please send off their tumor specimens for KRAS as well as BRAF, as well as other rare RAS mutation analysis. Do not provide oxaliplatin with cetuximab or anti-EGFR therapy in the setting of liver resectable disease. And please keep in mind that if the patient does have one of those rare RAS mutations, it can be detrimental to provide them anti-EGFR therapy up front. And last but not least, as you can see, there are various molecular markers that we are identifying. At the end of the day, the majority of them are in about 20 to less than 20% of our patient population. So it's likely you will see subcategories of colorectal carcinoma, such as the BRAF mutated patients, that basically will form these other rare subgroups of patients. And that's really where the field is going. You have a very common cancer, but once you categorize them based upon their mutation analysis, let's say BRAF as an example, which is in less than 10% of patients, that makes that patient a very rare subtype. So you're going to be seeing much more development and in regards to specializing your treatment, in particular to the molecular analysis of the tumor types of patients. And once again, I highly recommend, if possible, to try to get an evaluation on the site of metastatic disease rather than just the original colon or rectal tumor sample, because if that sample was obtained years ago, the quality of the specimen may also be jeopardizing the analysis of what your tumor looks like today. So I think that's about it. I thank you for your attention, and I will leave this up to the rest of the organizers. So I appreciate your participation. Thank you so much.
Dr. Eng, thank you so much for your presentation today. We have a few minutes. Do you have time for a couple of quick questions?
Sure.
Okay, great. At the beginning of the presentation, there was a question that was proposed in the chat asking what are the chances of small metastatic lesion on the liver recurring after FOLFOX treatment? The liver hasn't been apparent for 4 months, the lesion hasn't been apparent for 4 months on MRI.
So we actually have data that's been presented and published which has shown that even if a scan looks like it's negative for disease, if you were actually to put a needle in that site that was originally believed to be involved, it is likely you will find microscopic cells. Basically, with chemotherapy alone, your chance of complete cure is less than 10%. You are better off proceeding with surgical resection. So if you had a small site of disease development, our liver surgeons like to mark that area of tumor involvement so they know where to go to resect, even if you have a complete response radiographically. But I just want people to be very, very clear that even though it looks like it may be gone completely, the chances of that are not as likely. Likely there's maybe still some microscopic cells.
Okay, great. We have some specific questions about people asking about the connection with clinical trials in their area and their region, and I perhaps will, in the blog post follow-up, provide some feedback and provide some information, because there's some very detailed specifics in some of those. And so we will definitely reach out for the questions that have been posed that are very personal and very region-oriented for those of you who pose those. But in a more general sense, the question has been posed, is there a way to see which chemotherapy will be most effective? Well, how do you feel about chemosensitivity assays?
So the chemosensitivity assays have not been that helpful. And honestly, we don't have that many chemotherapy backbone options. So we basically have 5-FU alone, or FOLFIRI, FOLFOX, or irinotecan alone. So we know that combined chemotherapy is more beneficial to patients, and so basically in our viewpoint, both chemotherapy regimens are extremely helpful. They have different side effects. Not one is necessarily better than the other. It's very different versus biologic agents in regards to molecular marker analysis. The chemosensitivity assays have not been helpful at all in regards to oxaliplatin versus irinotecan.
Very good. And Dr. Eng, the other question that's just coming up, I noticed. I'm sorry, go ahead.
It's very important. For some reason, these slides have cut off all the references, and I think it's very important to acknowledge all the individuals that have shared these slides with me, as well as all the investigators, and all of these had actually had references so the viewers could find, where these slides came from and where they can refer to them. But unfortunately, all of these slides, the references have been cut off at the bottom, at least in my view. So.
Yeah, and they will actually, and when we've been forwarding them on the master screen, they have been apparent. So when they are provided, we will ensure that those are there with the citations. The other question that I just want to ask in general is there's several questions about clinical trial, and again, we will try to get back to the specifics. But Dr. Eng, can you provide information about, you mentioned upcoming trials, things that are in the hopper around, forthcoming. If individuals really want to link to specific clinical trials and be on the lookout, what is the best resource in terms of finding those?
Clinicaltrials.gov.
Okay. And people can, of course, look for those, and we will provide that link for everyone as well. So that's the best spot. Nothing specific colorectal, just that main site.
That would be the best site. That's what we use.
Okay, perfect. All right, good. Are there any biomarkers? Next question: are there any biomarkers to predict response to anti-angiogenesis therapy? Example, bevacizumab.
No, I think I showed that slide earlier. There's none that's been identified thus far.
Okay, that sounds great. We have just a couple other questions that are still coming up here. Just give me one sec. There's a question about a woman who had a sibling who has no standard risk factors, but last February was diagnosed with stage 4 metastases in her lung. She completed 12 weeks of I think it's fulfari and had a colostomy and rectal, and her rectum was removed 2 weeks ago. They have discovered 2 more tumors in the lung and one near the main artery to the heart. They're currently determining whether removal or targeted radiation is best. In those sort of situations, do you have any sort of insight about the course of therapy or recommendation to the family and loved ones?
Yeah, I can't provide recommendations based upon that case because obviously I don't know the original patient, and I would have to look at the records and et cetera. So I really don't want to provide an opinion on a case based upon a person's interpretation of where the disease is. I don't think that's appropriate because it's best to speak to that physician.
So I think that's the take-home message, is that relative to any of the situation, it's really most important to definitely circle back and provide very targeted questions for the physician in terms of a follow-up appointment. Just as Dr. Eng noted, it's very difficult to provide that kind of and probably not medically appropriate or responsible, but definitely taking time to consult a physician, or if needing more input, going to maybe even for a second opinion or the like, but definitely having a one-on-one and direct interaction with the appropriate medical records. Let's see. The one question then, it just falls out a little bit outside of the current recommendations for drugs and advancements, what have you, but is more relative to screening. But the question is specifically if there's more and more, as it's the appearance that there seems to be people that are younger than 50 being diagnosed with colorectal cancer, if you think that this might have any impact on screening recommendations as an overall population base.
No, not currently. The numbers are not big enough. The majority of patients are older. The median age is still 69, 68.
Okay, but I think it's just, of course, important for people to know family history and to know their own personal risk for, of course, thinking about meeting screening guidelines.
All people should be screened at the age of 50. And, of course, if you have a first-degree relative, you need to be screened 10 years earlier than their diagnosis. That is definitely a standard guideline. It takes 5 to 10 years for a polyp to become cancerous, so screening is extremely important.
Right. Okay, sounds great. And then Nancy, I know Nancy Butterfield, and we were going to talk a little bit about the resources. Thank you, Dr. Eng, for those answering those questions, and we just have a few more minutes. I think that also, though, in terms of thinking about the clinical trial matching services, Nancy, would you like to share a little bit about what CCA has available at this time?
Yes. Just wanted to let everyone know you were asking about where to go for, to find out about a clinical trial, and both Fight CRC and my CCA, the Colon Cancer Alliance offers clinical trial matching service, and it's free of charge. You can get a navigator that helps you, walks you through the whole system. You can either do it online or give them a call. It's very personalized, and just wanted people to know about that it's on both the Fight CRC and the Colon Cancer Alliance website, the link for those, so for clinical trials.
Nancy, thank you. And, you know, I was thinking about that specific to an overall umbrella, but that's exactly right. And thank you for sharing that information as well. I think that we are going to try to flip to the slide, and I'm sorry that during the intro there was a little bit of information that was provided about the CCA conferences and the like, and so we'll try to flip to that. Just a quick reminder to everyone that is on the line today and has joined our webinar. A special thanks to Dr. Cathy Eng from MD Anderson for providing the latest research and the like. I know that you know, we have a number of folks who are patients, but we also have providers as well as caregivers and a number of other individuals. And so I know that this information is the latest and greatest and can seem a little technical, but we've actually provided, I think, on both CCA as well as Fight CRC's website some additional supplementary materials in the way of one-pagers as well as videos and the like to understand the elements and the basic understanding of biomarkers, clinical trials, a bit further about the chemo agents as well as some of the research that was noted today. So if we need to take a little step back and really go back to the basics, those pieces and tools are there. But I can't thank Dr. Eng enough for spending the time to really go through the material and to understand what's really happened, actually, even and just been presented and advancements in the last year. So Dr. Eng, thank you so much for your time. Again, any questions that we didn't get to today, we are going to be blogging and following up. And once again, a reminder that this webinar will be posted on both the CCA website as well as the Fight CRC website. And Nancy, I'll just give you a final, turn the mic over to you for any closing comments.
Just happy to be here, and thank you all for coming, and look for our summits coming in the fall.
Okay, great. And we do have on the final slide the summit that's coming in the fall that Nancy just mentioned. The Colon Cancer Alliance website is there in terms of, and Cathy, can you just, or I'm sorry, Nancy, can you provide us just a small information again about this this event? Just a
sure.
small
well, in conjunction with the friends at our friends at CRIS for Life and Stupid Cancer, it's called Fighting a Smarter War on Colorectal Cancer, and the first one is going to be December 4th through 6th, and there's some specific groups that we're targeting there. It will all include newly diagnosed, long-term survivors, and young onset patients between the December 4th event and April 23rd through 26th. So as I said, the registration will start in the fall and sometime in September, so just check back for more information. You can also go on our website and click on, it will tell you all the information on our website, theccalliance.org.
Okay, very good. Thank you, everyone. We will be posting our upcoming webinar topics on the Fight CRC website, and I know CCA and the CRIS for Life also have additional resources. So thank you so much for your time today. Danielle, anything else we need to cover? Okay, and again, a sincere thank you for Dr. Cathy Eng for her excellence in clinical care and research.
Thank you, April.
Thank you.
Thank you. Goodbye.
Bye-bye.